Welcome again, everybody, to our fourth webinar of the year. Today, we're going to be covering a overview of multiple system atrophy and Lewy body dementia. So first, we'll hear from Dr. Katie Longardner, who's one of our center's neurologists or movement disorder specialists, followed by an overview of Lewy body dementia with another one of our center's neurologists, Dr. David Coughlin. I wanted to share one quick slide about housekeeping, and then we'll get going here. I can progress. Okay, so a few things to note. This is our annual education series. We're doing 6 sessions once a month and through December, so 2 more left after today. All of the sessions will be recorded and available on our website in case you need to log off early or miss any of the other sessions. So it'll be the recording link is on the same website that you registered at. And then any links or resources that are shared during the presentations, I will send to you via email after. So no need to jot any notes down in a hurry. So we are using the Q&A feature to answer any of your burning questions. You can find the Q&A little conversation bubble button, usually at the bottom of your screen. You can type in your questions at any time throughout the sessions, but we will get everything answered at the end of both presentations today. So with that, we'll get started. Dr. Longardner?
Okay, thanks. I'm going to share my screen. Okay. Can you see my slides?
Yep.
Okay, so thanks, Lisa. So I'm Katie Longardner. I'm a movement disorders neurologist at UCSD, and I also do clinical research. And my research focuses primarily on non-motor symptoms in the Parkinson's disease and related disorders. So we'll be talking about multiple system atrophy first. These are my disclosures. Relevant to this talk, I'm the site principal investigator for 2 trials for MSA and participated in a trial as a site principal investigator in the past for a medicine for treating orthostatic hypotension. So today I hope to discuss with you the overview of MSA, explain what it is, talk about the different symptoms that it can cause, learn how we as clinicians diagnose MSA, and then understand the symptomatic treatment options that we have for MSA. And then I'll finish by talking about upcoming research opportunities for people with MSA. Multiple system atrophy was named this way in 1969. Before that, it was described in America first in 1960 by 2 neurologists named Schei and Draeger. So it initially had the name of Schei-Draeger syndrome after them. Later, it was also referred to as striatonigral degeneration or olivopontocerebellar atrophy for the names of the brain regions that it affects. So, and then in 1969, Graham and Oppenheimer, 2 neurologists, decided to call it multiple system atrophy, thinking that it was a simpler way to describe this disease that affects multiple systems in the brain, spinal cord, and nervous system. It is a sporadic disease, meaning that the majority of the time it's not genetic. There's, as we'll discuss, not any strong known environmental risk factors for developing this. It's chronic, meaning that it is persistent. Once you have it, it continues. It doesn't go away on its own. It's progressive, meaning that it gets worse over time. And it's pretty rare. The prevalence is about 4 in 100,000 people, and the incidence or new cases per year is about 3 in 100,000 people. And it's a disease that affects, as I said, the brain, the spine, and the nerves. So it affects different parts of the nervous system and causes multiple different symptoms that affect movement. We call those motor symptoms, and other symptoms that affect other things besides movement, we call those non-motor symptoms. And one of the big features of multiple system atrophy is that it causes autonomic nervous system failure. So what is the autonomic nervous system? This is the network of connections throughout the body, from the brain to the spinal cord to all of the organs, that is kind of automatic, meaning that you don't have voluntary or conscious control over these bodily functions. This is further divided into the parasympathetic nervous system. This is sometimes referred to as rest and digest. So all of the functions that kind of slow things down, help you process your food, when you're relaxing, kind of. And then the other major branch of the autonomic nervous system is the sympathetic nervous system. That's sometimes referred to as fight or flight. When that part of the nervous system is activated, chemicals are released that increase your heart rate, raise your blood pressure, prepare you for stimulating situations, basically. And so multiple system atrophy not only affects the brain, as we'll talk about, but affects this complex network of autonomic functions that control the different organ functions. So multiple system atrophy can cause many different symptoms. It can cause problems with speech. The speech can be slurred or soft. It can cause problems with swallowing and choking on food or liquids. It can cause stridor, that is a high-pitched noise when people inhale due to contractions of the nerves around the vocal cords. Can cause changes in sweating, leading to decreased sweating. Problems with movement, including involuntary jerky movements or slowed or stiff movements, and also in coordination. Problems with walking, problems with balance, can cause constipation by affecting the gastrointestinal tract. It can cause changes in the bladder, including urinary frequency, meaning needing to go to the bathroom often, urinary urgency, having to go to the bathroom like right now, sometimes losing control of the bladder completely, meaning the urine just comes out. That's called incontinence. And also urinary retention, meaning the bladder doesn't empty normally. It can also cause sexual dysfunction, including erectile dysfunction in males. It also causes problems regulating blood pressure. So people with multiple system atrophy can have orthostatic hypotension, that is low blood pressure on standing, and have symptoms like lightheadedness, dizziness, feeling like they're going to faint, or even fainting from this. And then they can also have blood pressure that's too high when they lie down. So they have these extreme fluctuations in blood pressure that can also be very disabling when the blood pressure goes low. Multiple system atrophy can also cause changes in sleep. It can cause insomnia or trouble falling or staying asleep. And then one thing that's specific to this, and Dr. Coughlin might talk about this more later, is something called rapid eye movement behavior disorder, where people act out during their dreams at nighttime. So normally when we're asleep, in the stages of sleep when we dream, the muscles are paralyzed, but in these disorders, there's a disinhibition of the muscle movements that happen, and people can have very vivid, violent dreams. And they can punch or kick or yell out or even jump out of bed while acting out during these violent dreams. And then finally, multiple system atrophy can also cause changes in thinking and in mood. It can cause depression, anxiety. So this is just some of the symptoms, the most common symptoms that this disease can cause. What causes multiple system atrophy? We don't know exactly why this happens. We know that the pathology in this disease is an abnormal buildup of a protein that's called alpha-synuclein, and Dr. Coughlin would probably also talk more about this later in dementia with Lewy bodies, but the type of alpha-synuclein in multiple system atrophy is different from the kind in dementia with Lewy bodies and Parkinson's disease. Even though they're both kinds of abnormal protein, they're configured differently, and they're very different diseases. In multiple system atrophy, this protein affects kinds of nerve cells called oligodendrocytes. That is really the support network for the nerve cells in the brain and throughout the nervous system. And then this abnormal protein spreads to nearby cells and then throughout the nervous system. This on the left-hand side is a picture of these abnormal buildups in cells under a microscope. As I mentioned before, we don't know why MSA happens to some people. There's not any clear environmental risk factors. There was one study that showed an association between pesticides and development of MSA, but this was not confirmed on other studies. There was one study in France that showed working in an environment as a machine operator portended a higher risk for multiple system atrophy, but otherwise not really clear environmental risk factors. And there's been a few case series of families with multiple system atrophy. This is very rare, and again, not something that's widespread. There are certain families in certain regions of the world that have a genetic change that might be associated with multiple system atrophy, but not replicated in other parts of the world. So we still have a lot to learn about this rare disease. How do we diagnose MSA? It's mostly still a clinical diagnosis, meaning that it's based on gathering information from the medical history and doing a neurological exam. So to have the diagnosis, you need to see a neurologist that has some experience in diagnosing this condition. The things that we look for on the physical exam as clues are eye movement changes, speech changes could be slurred or soft speech, problems with walking or balance. We look at the muscle movement, coordination, looking for slow movement and rigidity. In MSA, there's kind of two main motor types. One type is called MSA Parkinsonism, that is more slow and stiff movements, and the other type is called MSA cerebellar subtype, and that is more what we call ataxia, problems with speech, eye movements, imbalance, and an incoordination of the movements. We're also looking for jerky movements that we call tremor. That is a rhythmic, regular movement, or myoclonus, that is more fast and irregular. And we also look for deep tendon reflexes. These are just some of the main things we're looking for on exam. There's a number of other diagnostic tests that we can use to help rule in or rule out MSA, but none of those other tests on their own are sufficient. This still have to have the neurological exam to look for these things. Other tests that we do to diagnose MSA include autonomic tests. So these are specialized tests done to check the function of the autonomic nervous system, as I showed you before. The caveat to this is that these tests are, for the most part, only done in a few specialized centers throughout the country. Not all of the academic centers have the equipment or the personnel or the expertise to do these studies. One such test is a tilt table test. That's a test where people lay down on a bed, strapped to the bed for safety, and then the table goes up and blood pressure is monitored continuously with a special machine. And we look for changes in the blood pressure to drop as people are upright. And so that can confirm the presence of orthostatic hypotension. And there's other types of changes we can look for in the heart rate to confirm that the low blood pressure is in fact due to a neurological cause. Other tests in the autonomic centers can do is a thermoregulatory sweat test. This is a test where people are covered in a special powder that changes color when it's exposed to sweat, and then they go into like a very hot room, and as the body sweats, the powder changes color, and we can see the areas of the body that don't sweat, and that can also help diagnose multiple system atrophy by the lack of sweating. There's another autonomic test that's a different kind of sweat test where it measures the conduction of electricity in the nerves in the skin. And then finally, specialized blood tests for a chemical called norepinephrine or noradrenaline. This is usually low in people with multiple system atrophy when they're laying down. So these are just some other tests that can be used. Again, none of these is sufficient by itself, but with the right clinical history can help confirm the diagnosis. Other tests that we can use are a brain magnetic resonance imaging, MRI. Things we look for are I'll just show some examples here of MRIs. A hot cross bun sign, that is the part of the base of the brain that has this hot cross bun appearance. The putamen rim sign, that is this loss of cells in the putamen of the brain that shows up as brighter here on the side. And then shrinkage of the pons and cerebellum. These are, again, the deep structures of the brain. And the cerebellum is the part involved in balance and coordination. And these are very small compared to usual. So those are some signs we can see on the MRI. This is just a zoomed in picture of the hot cross bun sign to show you this is kind of what it looks like. So how does multiple system atrophy compare to Parkinson's disease? There's a few major differences. Well, they have a lot of things in common, including the presence of this abnormal protein called alpha-synuclein. They both have problems with autonomic system failure. They have problems with the REM behavior disorder, the violent dream enactment. People with MSA are usually younger when it starts compared to Parkinson's disease. They have a faster progressing course, meaning that the symptoms get worse faster. They also have earlier onset of autonomic symptoms. In both of these diseases, the autonomic symptoms, so that is problems with bladder, sexual function, blood pressure, constipation, can all happen at any point throughout the disease. But in MSA, it's usually earlier and much more severe compared to Parkinson's disease. In multiple system atrophy, the motor symptoms are, again, faster progressing, and they usually have more trouble earlier on with speech and swallowing. And while they have similar symptoms as people with Parkinson's disease that affect movement, causing slowed or stiff movements, usually the medicines that we use for MSA don't respond well to levodopa, meaning that people could take levodopa but not have the same benefit that we usually see in people with Parkinson's disease. And then in MSA, people have this problem called ataxia. That's the word we use to describe the syndrome of problems with speech, swallowing, eye movements, and incoordination and imbalance. In MSA, people usually fall earlier on within the first 3 years. And in Parkinson's disease, falls this early are very rare, and usually the falls don't start happening until at least 5 years or more of living with the disease. And then in multiple system atrophy, cognitive and psychiatric symptoms are less common. So dementia is uncommon in MSA. In Parkinson's disease, it's more common, and people with Parkinson's disease tend to have more hallucinations, seeing or hearing things that don't exist, or delusions, that is fixed or false beliefs. That doesn't happen much in MSA. So we don't yet have any disease-modifying treatment for MSA, meaning that we don't have a way to slow disease progression yet, but we do have lots of things that can help treat the symptoms and improve quality of life. The treatment of some of these symptoms might worsen others, and so it's important to talk to your doctors about which ones are right for you, since the medicines we use to treat motor symptoms can worsen the blood pressure and cause worse urinary retention and constipation, for example. So I'm not going to say the names of all the medicines again, but just kind of go over the broad categories of medication and non-medication, things that can be used to treat the symptoms. For the motor symptoms, for Parkinsonism, stiff and slowed movements, we can try levodopa. That's the main treatment for the symptoms of Parkinson's disease. There are other medicines we can try for tremors and the jerky movements, and for dystonia or fixed posturing or spasms of the muscles. Medications can be tried, as well as Botox injections into the affected muscles, or botulinum toxin injections. And then physical and occupational therapy, as well as speech and swallow therapy, is really important part of treating the symptoms from this disease, specifically focusing on balance and improving function. For the low blood pressure on standing, the first thing that we do is to look at the medication list and try to minimize or get rid of any medicines that could contribute to the low blood pressure. People can drink more water. It's recommended at least 2 liters or 64 ounces. That's 8 cups of water a day. You can wear compressive garments, thigh-high or waist-high compression stockings, or an abdominal binder as shown here. These help to improve the blood flow from the legs and the lower body back to the heart to reduce the low blood pressure when people stand up. Lower body strength training can have the same effect by strengthening the leg muscles. When people stand, it improves the pump function of the legs, increasing blood flow to the heart, reducing orthostatic hypotension. Adding salt to the diet can also help. Raising the head of bed at night helps prevent the blood pressure from getting too high overnight and then causing worse low blood pressure in the morning. So putting a wedge under the head of the bed, simply adding pillows is not enough. And then finally, there are medications we can use to raise the blood pressure more to prevent the blood pressure from going so low when people stand up. For constipation, again, we want to remove any medicines that can be contributing. Drinking water, adding more dietary fiber, exercising can all help move the bowels. And then there are also oral medications we can use to treat constipation. For urinary symptoms, also there's medications we can use. Botulinum toxin, injections in the bladder can help. More invasive procedures such as a tibial nerve stimulator device, or if the bladder has trouble emptying, we can do catheterization where a tube is put into the bladder and the urine drains from the tube into a bag. For erectile dysfunction in males, there are medications that people can take by mouth or actually insert into the ureter before sex. There are other devices such as rings, injections into the penis that can help treat erections, and then other devices that can be used. For rapid eye movement behavior disorder, acting out the dreams, there are medications people can take before sleep that can help prevent this. And then the sort of practical thing is to modify the bedroom environment, getting rid of any furniture, electronics, or things that could break when people are thrashing around during their sleep. This is just to prevent nocturnal injury. For the stridor, again, that's the high-pitched noises that can happen from contraction of the muscles that can lead to trouble breathing sometimes in people with MSA. They can wear a sleep mask at nighttime that helps maintain the pressure into the respiratory symptoms. And then in very severe cases, sometimes a tracheostomy is done. That's a procedure that puts a hole into the front of the neck that goes down the breathing tube. And this can also help prevent that and keep the airway open. And then briefly, I'll just talk about the research opportunities for people with MSA. Here at UCSD, we currently have 2 trials that are ongoing with the enrollment closed for both. These are the ones on the top of the screen. These are both randomized placebo-controlled trials, meaning that when people enroll in the trials, we don't know if they're getting the study medication or a placebo or sugar pill. These are both different kinds of experimental treatments for MSA. One is a medicine that binds to iron to reduce iron buildup in the brain that we think is perhaps part of the pathology for MSA. And then the other one is an alpha-synuclein antibody infusion. We have 2 upcoming for MSA that haven't started recruiting yet, but will in the next year or so. One is a treatment trial of an oral medication for treatment of orthostatic hypotension in MSA, so symptomatic treatment of low blood pressure on standing, and then another disease-modifying experimental medication coming up, probably will start enrolling in late 2024. And then you can also search at this website here, clinicaltrials.gov, to stay up to date on all of the treatment trials and observational trials for people with MSA. Here's a few resources for MSA to learn more about the disease. The first one, MSA Coalition, is the most comprehensive, but the bottom 2 also have a lot of good information about this disease. And then finally, just would like to thank the research team and the clinicians here at UCSD. If you have any questions or comments or are interested in participating in any of these clinical trials, you can email me here at the bottom. And with that, I think my time is up. So I'll stop the share and then turn it over to Dr. Dave Coughlin, who will tell you about dementia with Lewy bodies. That's another disease kind of related to MSA.
Thank you, Dr. Longardner. Just get a moment to get my screen squared away. Okay. I think we're good to go. So thanks to everybody for attending on this Friday morning. My name is Dave Coughlin. I'm an assistant professor, a physician and scientist here at UC San Diego, working with the movement disorders group here. We're going to talk about Lewy body dementias with a focus today on some of the clinical aspects, some of the biomarkers that we use to help diagnose Lewy body dementia, including a couple of things that are coming down the pipeline now, and a little bit of treatment overview. Interestingly, the structure of our talks are very similar, so you'll see a lot of parallels here. Let's go. Okay, I don't have any disclosures that are relevant to this talk, although we are going to be talking about the off-label use of a handful of medications. And here's my current research and recent research funding information from the NIH. So I wanted to start with some basic definitions because talking to people in the clinic, sometimes this gets a little bit confusing. So I want to just talk about the idea of dementia in general. So dementia is an umbrella term, and it's meant to describe just a state where there is significant alterations in cognition, memory, or thinking, such that it gets in the way a lot in people's regular day-to-day activities, whether that's social interactions or trying to perform simple tasks like, balancing a checkbook or cooking anyway. There's many things that cause dementia, though. We all think about Alzheimer's disease a lot anyway, and it's true that Alzheimer's disease composes probably the majority of dementia cases out there, but there's other things that cause it too anyway. Vascular dementia, where repeated strokes or small vessel changes will sometimes cause brain dysfunction that'll end up meeting criteria for dementia, is probably the second most common thing we think. But then the Lewy body dementias come in number 3. And I've heard other talks given by people who I respect a great deal who call Lewy body dementia the most common disease that you've never heard of anyway. But we're going to talk a little bit more about it today. But even within Lewy body dementia, there's really 2 big types anyway. There's the Parkinson's disease dementia, and then there's dementia with Lewy bodies. So not making things any easier with our terminology. With Parkinson's disease dementia, we're talking about people who've had Parkinson's disease, have a movement disorder, and typically that progresses for many, many years, and cognition is fine. And maybe like 10 or 15 years down the line, they start noticing problems with memory. With dementia with Lewy bodies, the memory problems either happen first or happen in very, very close proximity to the movement changes anyway. So the order of some of these symptoms are a little bit different, but they share a lot of things in common. The types of cognitive changes in DLB, dementia with Lewy bodies, and PDD, Parkinson's disease dementia, are very, very similar. Both conditions have visual hallucinations as part of their core criteria. Many people will also develop cognitive fluctuations, constipation, loss of the sense of smell, and the REM sleep behavior disorder sleep issue that Dr. Longardner mentioned. We're going to go into some of these in greater detail in a moment. And truthfully, even if you look at these brains under a microscope, both DLB and PDD have the same alpha-synuclein protein that's misfolded and creates Lewy bodies in both of these diseases. And truthfully, it's in the same brain areas. So there's a lot of overlap between these conditions. We're going to focus mostly on DLB type stuff today, but again, when we talk about some of these issues, you're going to recognize a lot that is applicable to Parkinson's disease as well. So we're going to talk a little bit about the dementia with Lewy bodies clinical features. So again, there must be memory impairment to diagnose this, and it has to be fairly substantial and progressive declines in memory and thinking. And then these core features include fluctuating cognition, visual hallucinations, movement disorders, things that relate to Parkinson's disease, and the sleep problem anyway. You don't have to have all of these things, all of the core features anyway. You can at least have a couple of them for us to make a proper diagnosis anyway. As far as the memory impairment with dementia with Lewy bodies, these are some different areas of memory and thinking that are disproportionately affected. People have a much harder time with attention. Might be hard for somebody to hold a phone number in their mind anyway without writing it down. Executive functioning becomes difficult. Planning multi-step things, cooking is difficult, I mentioned. You know, if you get interrupted while you're doing a particular task, it might be very easy to lose it anyway. Some people have problems with visual spatial function, as in it might be easier for them to get lost while they're walking around or driving in the early stages. For things that we do in the clinic, they may have trouble copying the figures or judging line orientation issues. And there's some examples of some of the little cognitive tests that sometimes we do in the clinic anyway. Short-term memory tends to be less affected in dementia with Lewy bodies than Alzheimer's disease. So there's usually less of the sort of repeated questioning, less problems with having the same conversation again and again with loved ones. That type of problem we see more often in Alzheimer's disease versus dementia with Lewy bodies. Cognitive fluctuations, this is an interesting feature that's a little bit hard to interview for in the clinic, but these are just spontaneous changes in arousal and attention. There can be periods of people looking like they're pretty normal, and then fairly sudden onsets of people having fairly intense confusion, even very sleepy and hard to arouse or wake up. They can have a lot of slurred speech or even just be staring off into space for a while anyway. And in their more severe forms, like this will often prompt a few emergency room visits. You know, family members will be concerned that this person is having a stroke or a seizure. They go to the emergency room, big old workup. Usually they don't find anything and they get sent home. Eventually we make it to one of us in the neurology office, and after all these rule outs, we say, you know what, this might be actually a cognitive fluctuation anyway. If we're interested in the biology of cognitive fluctuations, we actually think that these are probably due to sleep architecture getting kind of messed up in dementia with Lewy body disease, where the brain structures that are implicated in allowing us to remain awake suddenly become offline or dysregulated, and this causes this big fluctuation in how awake we are or how cognitively with it we are anyway. Visual hallucinations are sort of another core feature of dementia with Lewy body disease. Again, these are mostly visual. You see things that aren't there. They tend to be well-formed, spontaneous objects. So like little bugs on the floor or the wall, animals, snakes, little rats or something, sometimes children or other people in the room when they are not there. There's sort of less severe versions also of this, what we call presence or passage sensations. And actually many of us will have this anyway, the feeling that there's somebody in the room or right off outside of your vision and you can't quite catch them, or something that kind of flies across your vision, you didn't quite catch it anyway. Those are sort of presence and passage sensations, are sort of low-level hallucinations anyway. And then there's also what we call illusions, where it's kind of a sensory trick where things will arise from other objects. You know, you're looking at a cloud and suddenly it looks like a face, or there's a person who kind of emerges from the curtains or the trees anyway. So these are sort of early stage visual hallucinations, and these are pretty common in DLB. They're probably there in at least 80% of patients at some point, usually pretty early on too. Parkinsonism, this is also a core feature of dementia with Lewy body disease, and people usually have at least one of the following. Some degree of stiffness of the arms, leg, or neck, slowness of movements of the hands or the feet, sometimes a resting tremor, that can happen as well anyway. And the Parkinsonism anyway that happens with DLB tends to be less levodopa responsive than regular Parkinson's disease. Oftentimes we will still try levodopa as a Parkinson's medication in DLB anyway, but we have to be a little cautious with it and go slowly anyway. There's a whole bunch of other things that can happen with DLB that we call supportive features. We mentioned a little bit before, but oftentimes people will lose their sense of smell. Sometimes people are aware of it, but not always. Balance can be affected pretty early on, leading to falls. Patients will often also have lightheadedness when standing, which is accompanied by a drops in blood pressure. It's a very severe problem in multiple systems atrophy, like Dr. Longarder mentioned, but it also occurs in DLB2, often a little bit less severe. People will also have constipation. You may have hallucinations in other modalities too, like you hear things instead of seeing things. Sometimes delusions are part of this as well, as are other mood disorders, including anxiety, depression, and sometimes some apathy as well. There's really a lot of things that can be affected in DLB. We do try to talk to as many of these as we can in our clinic visits. Everything that I talked about so far is really based on a conversation that you would have with a physician and a physical exam that that person would do. Do we have other tools that help us to diagnose dementia with Lewy body disease? We have a few. There's a couple of neuroimaging studies that can be helpful. They're not perfectly specific, but they're helpful in the right clinical context. MRI of the brain. I think most people would get one of these in these types of situations. The number one over here is a picture of an MRI of the brain anyway. This is a normal person anyway. And what these red boxes are actually highlighting is some memory structures of the brain. And this is a pretty good looking memory structure, pretty good looking hippocampus in the normal person here. It actually looks pretty good in the patient with dementia with Lewy bodies, but in Alzheimer's disease, it's very, very shrunk. So an MRI can be useful at trying to get some hints at differentiating Alzheimer's disease from dementia with Lewy bodies. Similarly, FDG PET, which is a modality that uses a radio-labeled glucose to see how metabolically active certain brain area parts are anyway, that can be somewhat helpful. And what we see is these green areas show decreased activity, decreased metabolic demand anyway. And in dementia with Lewy bodies, especially out in the back of the brain, that also gets affected much more so than what you see in Alzheimer's disease. This is a nice color scale, which makes the visualization easier, and you can see the same thing on a grayscale. A DAT scan is something that somebody might order as well. This is another type of cousin of a PET scan anyway, where people are given a tracer that binds to dopamine terminals in the brain. And the DAT scan can also be useful at differentiating DLB from something like Alzheimer's disease, although DAT scans are also abnormal in Parkinson's and other conditions as well. But a normal person has these big comma shapes that are very bright. This is dopamine reuptake terminals in the deeper structures of the brain. You see it's also pretty normal in an Alzheimer's patient on this side, but in DLB, there's a lot less. And the damage to these structures is probably what's important for causing the Parkinsonism aspect of the DLB anyway, and we can see that a little bit on this type of scan too. Cardiac imaging can be a little bit helpful. This wasn't available where I trained, but you can get it here at UCSD and some other places around the country too. But it turns out that the nerves that actually go to the heart are actually decoupled a little bit in dementia with Lewy bodies. And you can see that on these cardiac scans anyway. This is a normal person who has the circle is supposed to be where the heart is supposed to be, and you see some black, which is a good thing. It's taking up some tracer. It's absent in the person with DLB, and it's present in the person with Alzheimer's disease. If you're interested, this is the thyroid, this is the liver, and these are the lungs, but this is where the heart shadow is supposed to be, and it's absent in the DLB case. There are some things that are coming down the pipe that are pretty close to being applicable in clinic anyway. The two synuclein specific biomarkers. So if you maybe remember from like my second or third slide, when you look at the brains under the microscope of patients with dementia with Lewy bodies, you'll see accumulations of alpha-synuclein, which little protein that gets misfolded, clumped up, and a bunch of other things attached to it. And we can actually see that. But we are getting better at measuring those misfolded proteins in different parts of the body that we can actually access to people while they're alive. There's a pretty good spinal fluid test that's been developed over the last 6 or 7 years now. It does require a spinal tap for us to get fluid to send off to this lab. Amprion is the company that sends these right now. And the other biomarker is actually derived from a skin biopsy, which is another thing that people can do in the clinic anyway. Very simple 3mm punch biopsy. Many people will have gotten something similar at the dermatologist's office. Doesn't need a stitch or anything to close it up. And people can actually see a little bit of alpha-synuclein in some of the very, very small nerve fibers that go to like our hair follicles and our sweat glands. CND Life Sciences is the company that's pushing that one anyway. I do want to make it clear though that like these are CLIA certified tests, but have not like finished the whole FDA regulatory approval process. And part of that is that it's not very well covered by insurances yet anyway. But we're watching this space anyway so that we can hopefully bring some of these tools to more patients as insurance companies start covering them. And I think that the utility of these will ultimately be to be a little bit more certain about whether we're dealing with a DLB case, because we can show that there's actually alpha-synuclein proteins being aggregated in these fashions. Let's switch over to treatment. So similar to MSA and many of the diseases that we work through and fight with in clinic anyway, we don't have any cures. We don't really truthfully have things that necessarily slow it down yet. But we do have therapeutic things that we can offer to help treat many of the symptoms of dementia with Lewy bodies and Parkinson's disease dementia too. As far as dealing with memory and thinking problems with cognition, medications like donepezil and rivastigmine and some of its cousins actually have some evidence to be helpful in dementia with Lewy bodies as well. Another memory drug that's been around for a long time, memantine, use is a little bit less clear, but many of us will try it as well. If people are suffering with visual hallucinations and delusions, sometimes those same memory drugs can be mildly helpful, but truthfully, a lot of us will have to use other things in addition. Things like quetiapine, also known as Seroquel, or pimavanserin, also known as Nuplazid, and a very old drug that we don't reach for a ton called clozapine too. Most of the studies for these drugs have truthfully been done in Parkinson's disease anyway, but we do often will extrapolate a little bit for its use in dementia with Lewy body disease as well, and we usually get decent results with it. As far as the Parkinsonism that's related to dementia with Lewy body disease, I think that most of us, if Parkinsonism is severe enough, would at least try low-dose carbidopa-levodopa and slowly increase it over time. You just have to watch that it doesn't exacerbate any of the visual hallucination problems anyway. We tend to try to avoid certain medications that can make memory and thinking worse, including a whole class of drugs called anticholinergics. And while there are a lot of other drugs that can be useful to treat Parkinson's disease, most of them cause some fairly nasty side effects for our DLB patients. So we really stick to the carbidopa-levodopa for DLB patients. If REM sleep behavior disorder is particularly bothersome and there's a lot of acting out of the dreams and we've knocked over the lamp a few times and fallen out of bed, we'd probably try to treat it, honestly. And you can do that with over-the-counter melatonin. I usually start with at least 5 milligrams for your average size adult. I can work it up to 4 times that amount without any major issues for most people. And a little bit more heavy-handed and to be used with caution and very low doses, maybe clonazepam that can help with specifically that sleep problem too. Dr. Longardner went in depth with orthostatic hypotension, which is the problem where when you stand up too fast, that your blood pressure drops really quickly and people feel very lightheaded and can cause falls. We do emphasize fluid intake, salt intake, and maybe even compression stockings and binders as non-drug ways to work on this problem. But we do have at least 3 drugs that we can work with anyway that can help raise the blood pressure a little bit. So fludrocortisone, which is a drug that helps your body hold on to salt a little bit better. Midodrine, which helps your blood vessels squeeze a little bit more anyway and keep your blood pressure a little higher. And droxidopa, which is a precursor for another metabolite that helps increase your blood pressure as well. So there's at least 3 tools that we can work with. I see many people in clinic complain a lot about fatigue and somnolence, a lot of sleeping during the day. This is hard. This is a hard problem to treat anyway. Sometimes we'll recommend increasing caffeine intake a little bit. We don't have awesome medications to keep people awake, at least not in a way that's safe, and that won't make some of the other problems worse anyway. But we sympathize that this is a problem that really could use a different strategy that's not totally available right now. As far as gait instability and falls anyway, we do usually emphasize physical therapy a lot. Most of our patients will go to physical therapy periodically anyway to help get refreshers on gait training and help fight deconditioning. Many people will need gait assistance devices like walkers to help them be safe when they're moving around too. Occupational therapists can be helpful, especially for home safety evaluations too. If there's easy things around the house to fix to lower the risk of falls, it's usually a useful thing too. Problems with chewing and swallowing, also known as dysphagia or voice volume. We usually will ask if people would like to get involved with speech therapy, and sometimes they'll give exercises to help people project their voice a little bit louder, and they may suggest different diet consistency modifications to help people eat and chew properly without hopefully putting any food down the wrong pipe. Drooling is a problem for some people. We usually will work with botulinum toxin injections, which people get every 3 months to the big glands in your cheeks anyway, and that helps slow down the drooling a bit. For depression and anxiety, the typical SSRI type medications like Prozac or Zoloft or any of its cousins also seem to work a good bit for this too. And then there's always advanced care planning too. We usually try to emphasize that patients should discuss their wishes for their medical care with their family members early. These are conversations that are much better and much more comprehensive when people are relatively well and can express their wishes more fully. I think most neurologists are pretty comfortable with having these conversations, but we also have subspecialists in the palliative care department who can aid in symptom management and navigating some of these issues with advanced care planning if needed. And getting in touch with an elder law attorney is always a good idea as well, as sometimes there are changes to wills, trusts, and assets that might be beneficial to do. So as people get older and if these diseases advance, it might help protect family finances as well. I'm going to talk a little bit about some of the research opportunities here at UC San Diego as well. As far as our DLB-centric studies, there's kind of two that are getting going now. There's one called the SIGN-D study, which is helping to validate some of these skin biopsy studies. It's basically 2 visits. That's for people who have very, very early stage Lewy body dementia. There's a medication trial that's enrolling right now called the Rewind LB study, and this drug may improve cognition in Lewy body disease. And then there's 2 other studies that could be either for dementia with Lewy body disease or for people with Parkinson's who have memory impairment. And there's a 30 to 45 minute just simple phone study that's just going to ask about environmental risk factors that, basically ask you about your life and some of the things that you did for a job or where you lived anyway, to see if there's any associations with environmental exposure and increased risk of developing Lewy body disease later on. That's a pretty easy one to get involved with, honestly, because it's just this simple phone survey. The more involved DLB and PDD study is the DLB consortium study, where people get basically yearly clinical assessments, including blood and spinal fluid sampling and a whole lot of imaging studies as well. And we've been a DLBC site for quite a while anyway, and follow several patients for quite a bit now. If you're interested in learning more about any of this stuff, you can either email Ileana Rubio. I put her contact information down there, or if you just Google UCSD movement disorders and go to the research part of our website, you can read a little bit more, and you'll find the same contact information there as well. And then lastly, similar to Dr. Longardner, there are some resources that are out there. The Lewy Body Disease Association is a national organization, probably the biggest and most comprehensive one in the United States. It offers a lot of patient-centric information about Lewy body disease and support groups in our area. The Parkinson's Disease Association of San Diego is very, very good as well. And yes, they do a lot of Parkinson's work, but they also have some resources for other conditions as well, like dementia with Lewy bodies too. And even the Parkinson's Foundation itself anyway, which is another US-centric program, has some stuff for people with Parkinson's who may be experiencing memory problems as well. So there's kind of a spectrum of things. And I would encourage you guys to check out all 3, to be honest, and see to learn more about all of this stuff, and hopefully find some resources that you'll find useful. That is all I have right now. I'm going to stop sharing. And I think we get to open it up to the Q&A session now, right?
Yep. Thank you to both of our presenters for sharing all that information today. And to our attendees, I hope you found those presentations really helpful and useful. We hope to build on those topics in the future.